But there is a qualitative difference between just using a substance and actually becoming addicted to it. Don't let anybody tell you that all there is to addiction is getting high. Don't let anybody tell you all there is to addiction is self-medication. Both of them are significant psychological components on people using drugs. Somebody uses substances and then stops. They can be very hopeful that their brain has a good chance of healing several parts of it and going back. But on the other hand, they should be very, very careful not to ever challenge themselves with a particular substance because the addiction is there to stay.
I'm Dr. Esra Çavuşoğlu, and I've been living a sober life for the past 18 years. My battle with addiction drove me to seek new methods, devices, and supplements to improve my physical and mental performance, enhance my quality of life, and ultimately live healthier for longer. From my experiences in addiction recovery, biohacking, and longevity to the latest global developments, from groundbreaking entrepreneurs to expert academics, the conversations I've had over the years are now featured weekly on Soberhead Podcast. This week at Soberhead Podcast, I have Dr. Petros Levounis, who is a prominent figure in psychiatry, particularly noted for his expertise in addiction psychiatry. He serves as the professor and chair of the Department of Psychiatry at Rutgers, New Jersey Medical School, and is also the chief of service at University Hospital in Newark. Dr. Levounis studied chemistry, biophysics, and sociology at Stanford University before earning his medical degree from the Medical College of Pennsylvania. He has held significant leadership roles, including Director of Addiction Institute of New York at Columbia University, where I had a chance to work with him, and notably President of American Psychiatric Association, where he has been an active advocate for LGBTQ mental health. His extensive scholarly contributions include over 14 books on topics ranging from motivational interviewing to the treatment of co-occurring psychiatric disorders, demonstrating his profound impact in the field of psychiatry. In this episode, we are detailing substance use disorder and the brain and answering many of the questions that I keep receiving from you. Now, let's go to the episode. Here is something that is fascinating. A huge amount of people who watch this channel frequently are not subscribed. So I want to ask you a quick favor. When you subscribe, it helps us to make the show better, access to the world-leading experts, and ultimately bring you more value. All that I ask is for you to hit the subscribe button, and in return, I promise we will make Ayık Kafa better every day. So welcome, Dr. Petros Levounis, my dear friend. Welcome to Soberhead, and you can understand that even the name of the podcast is related to my sobriety. We go back a long time. You know, I had the honor of being able to do my internship under you. So that was great.
Thank you so much for having me here, Ezra. It's absolutely wonderful seeing you again after all these years. I know we have kept up virtually and all that, but it's wonderful to see you in person here. So, I'm a professor and chair of the Department of Psychiatry at Rutgers, New Jersey Medical School. I am the immediate past president of the American Psychiatric Association.
What made you interested into addiction psychiatry?
It was a synergy of several things. I would say that I had a passion, and I still do, for very small things, for chemicals, for molecules, for organic chemistry. And I'm also fascinated by very large things like social structures and social determinants of health and sociology and the like. So if you put the two and two together, having a passion for chemistry and molecules, and then loving the public policy and cultural aspects of psychiatry, that pretty much spells addiction psychiatry. But that's not the only thing. The other major component, perhaps much more important than the chemicals and the policies, is the humans. People who live with substance use and substance use disorders, truly wonderful and fascinating to me. I was fortunate to have gained access to the Betty Ford Center as a medical student. They used to have a program there where you would join the Betty Ford for a week, pretty much like a patient. Everybody knew that you were a medical student, but they treated you very much like a patient. So it was an experiential program that really defined me as a psychiatrist, and more specifically as an addiction psychiatrist.
You did your medical degree at Stanford University, if I'm not mistaken, correct?
I did half it at Stanford and half at the Medical College of Pennsylvania. And then I came to New York, where I did my residency at Columbia.
And you worked for a long time in the addiction field. Now you moved more into the teaching part, I guess?
No, I'm still an addiction psychiatrist, and I'm also the director of the Center of Excellence for Medications for Addiction Treatment in New Jersey, Northern New Jersey. So a big part of my responsibility has to do specifically with the treatment of addictions.
Petros, the purpose of my podcast is to educate people about addiction, about supplements, about biohacking, about everything that they're not having access to. Because we're not only recording in English, we also translate it so people who doesn't speak English have a chance to understand all these advanced science in Turkey. So over the years, over the decades, let's say, addiction keep changing the name. It was the dipsomania, then the addiction, now it's the substance use disorder. Can you give a bit of a history of, in your understanding, where was it and where is it now? How do you see it?
Some time ago, people thought that only substances that result in physiological withdrawal, things like alcohol or opioids, are true addictions. And for example, for a long time, cocaine was thought not to be a true addiction because you didn't have the robust physiological manifestations of cocaine withdrawal. Until Herb Kleber and colleagues described a very specific psychological withdrawal to stimulants, cocaine, crystal methamphetamine, and other stimulants, at which point they also were thought to be addictive substances. So we've come a long way, and now, of course, we appreciate not only a number of substances that can be addictive, but also behaviors. The DSM-5 took a revolutionary step in including gambling in the addiction chapter. It used to live somewhere else in the DSM, in the impulse control disorders, and very correctly it migrated and now is considered to be one of the addictions. And of course, since then we have expanded even farther, and we're going to sex addiction, internet addiction, the other technological addictions, several behavioral addictions that seem to go through very, very similar channels in the brain as the classic substance use disorders like alcohol and cocaine and opioids.
You jumped ahead. I had these questions as well, but no, that's great. That's wonderful, because then I can start asking questions around what you just explained. So can you please explain how can it affect the brain the same way while one has literally some molecules passing through the blood-brain barrier and affecting the communication of the brain? The other ones are through, yes, dopamine rise, but not much of anything getting in the brain. So how can you define them?
The chemicals entering your brain are quite important, very much, as you said, hijacking the dopaminergic system in the brain. But we now identify other things that can very well hijack the dopaminergic system in the brain, and these are the behavioral addictions. The way that I think about it is a grand funnel. Different substances affect different systems, different neurotransmitters in the brain, and behaviors may go at also different parts of the brain which are not as well understood as the substances. So let me make sure about that. But ultimately, all of them end up kind of merging into a very similar pathways. It's not only one pathway that defines the addiction in the brain. As we now understand, it's not only the dopaminergic pleasure and reward systems that get affected, but also several other components like the anti-reward pathways of the brain that may actually define the addiction in the long run more so than the dopamine system.
Since it's changed the description in the ASM and the DSM, that from the dependency and abuse to the substance use disorder, mild, moderate, severe, it's making it a bit difficult, at least from my end. It used to be so much easier. Yeah, this is the dependence period. You're abusing, you're not yet there. Like, what are the differences? What do you look at to make this diagnosis?
Okay. here is how it goes. We used to have, up until the DSM-5, a minor syndrome and a major syndrome, in a way. We used to call that substance abuse was the more minor part of the disease, and then dependence was the major part. And correctly so, DSM-5 got rid of dependence and abuse and made it all in a continuum and called it mild, moderate, and severe. And I fully understand and support that. However, the reason why we switched from the major and minor to this mild, moderate, and severe had to do with epidemiological factors, that there was not enough evidence to support a way of defining what's the difference between minor and major. However, from a neurobiological perspective, we continue to believe that there is such gap, maybe not quite as crisp as once thought, but there is a qualitative difference between just using a substance and actually becoming addicted to it. And we're not quite sure where it falls in the mild, moderate, and severe DSM-5 description. I would say most of us think that moderate and severe signify addiction, while the mild part may be more in tune to what we used to understand as a minor condition.
It's very confusing because, when you look around, even among friends, like you can diagnose almost everyone with the substance use disorder. Then everybody's in the same basket. It's very difficult to make the differentiation. So that was a great way that you put it out. So, I've been in a couple of lectures of yours, obviously, when I was at St. Luke's Roosevelt with you, because people are asking me, what happens to the brain? So what happens to the brain? You had this, like, either the 3s or the 5s, like the trilogy, almost like the 3 days physical withdrawal, 3 months. Can you explain what happens to the brain?
I'm so delighted that you remember this,
I
do. From many years ago.
I use it a lot with my people.
So there's a classic saying in general medicine that humans can live for 3 minutes without oxygen, for 3 days without water, and for 3 weeks without food. So that's the rule of 3s in general medicine. And we have adopted that in addiction medicine, and we often say that 3 days signify the acute withdrawal from a particular substance. 3 months is the protracted withdrawal, where the symptoms still linger from the withdrawal, but you don't have the robust physiological manifestations of withdrawal. And 3 years as a measure, as a milestone for saying that somebody is in stable sobriety. Let me just make the point here that the middle one, the 3 months for the protracted withdrawal, is something that Alcoholics Anonymous have said many, many years before neuroscience caught up with things. Remember AA, 19 meetings in 90 days? So there's a wisdom in these hallmarks that AA and other mutual help groups have proposed, that they were ahead of science and ahead of medicine.
What are the symptoms in that 3 months period that one should look? Probably depends to the substance that they're using, but...
Not as much. Not as much, because the first 3 days obviously is a period that's very specific to the particular substance somebody is using. But the 3 months is a little more generic. And it touches on what George Koob and colleagues call hyperkatifia. It's a wonderful Greek word, but it hasn't caught on because it's such a difficult word. But it signifies a state of malaise, of dysphoria, irritability, annoyance, anxiety, insomnia, that the person feels, of just being not only depressed in a way, but much more irritable and kind of on the edge. And that is what is particularly prominent in the first 3 months of sobriety. It does continue further out, but less so.
So like an emotional withdrawal in a way.
It is an emotional, I see it, of course, as a physiological one as well.
Yeah.
Think about all these neurotransmitter systems trying to normalize. So they went through the big shock of the acute withdrawal, and then little by little, they try to regain their equilibrium and their homeostasis.
So when you said 3 years for like fully recovery to bloom, let's say, how do you guys decide on that time period?
No, that is the least scientific. People who are in sobriety know very, very well that it's a lifelong process.
Sure.
And they may actually roll their eyes of me even saying the 3 years. I can stand behind the 3 days and the 3 months. I have very little to stand on to justify or defend the 3 years. I think it completed the 333 kind of analogy.
I think that there is a truth in that, though. Alcoholics Anonymous talks about that 1 year mark. You said the 3 year mark. So it probably takes a minute for that brain to heal. So you're kind of talking about that. You're not talking about a lifelong working on your recovery, more like the physiologically, that something has to repair itself.
Ezra, don't push me anymore on the 3 years.
No, but
well. It's just I cannot really defend
Or
it.
let me ask it this way. I don't want to push you. So how long it takes the brain to heal?
Excellent question. I'll answer that one. And then I want to go back to the 1 year mark, because that's a fascinating one as well. When you think about the effects of substances and behaviors on the brain, it's helpful to think of two major buckets. One is the direct toxic effects of substances that they may have on the brain, the way that they occasionally chew different tissues. We know that, for example, with alcohol, heavy alcohol use, some memory problems, and sometimes all the way to dementia and the like. So this is the direct toxic effects of substances in the brain. The other major bucket is the installation of addiction, the vulnerability of the person to go back to using, even if they have stopped using the particular drug. On the first bucket, on the direct toxic effects of substances in the brain, we have good news. The more we study the brain and the more we study substances, the more hopeful we are that the body is quite forgiving. Maybe not completely, not for all substances, but much more forgiving than we ever thought before. So this is good news. There is a repair of the tissues. A lot of the function comes back. The downhill deterioration stops and the like. On the other hand, that second bucket that has to do with the addictive engraving in the brain, that one most likely is more long-standing than we ever thought before. So what I'm saying here is that if somebody uses substances and then stops, they can be very hopeful and very optimistic on the fact that their brain has a good chance of healing several parts of it and going back. But on the other hand, they should be very, very careful not to ever challenge themselves with a particular substance, because the addiction is there to stay. We're not sure if it's lifelong. That is still a question mark for our scientific community. But what we do know is that even if the brain goes back to the state that it was before the person started using the substances, it is not a matter of weeks, it is not a matter of months, it is not a matter of years, it is probably a matter of decades.
So let's talk about the first bucket. How long it takes the brain to heal itself? Or can it heal itself by itself, without therapy, without AA, without nothing, just not using, would it heal?
Yes. The answer is yes. There are strictly physiological components that do bounce back, as I said before, not for everything and not for all substances. Interestingly enough, the beginning of this kind of thinking came with tobacco. When we were amazed by how much the body healed itself, our lungs and our hearts and so on, with cessation of smoking, of tobacco cessation. And that kind of research has expanded into the brain as well. So, yes, that I would say is good news. Not across the board, not for all substances, not for all effects of the substances, but much more so than we ever thought before.
I just received a call today from a guy that I helped him, not helped him as a therapist, but, he called me. He was a friend of someone that I know, and he wanted to stop using drugs. He went to a rehab. He was sober 1 year. Yesterday, he reached out to me. He was still sober, but thank God he was smart enough. Said, you know what? I started having thoughts. Maybe I can use ketamine. This seems challenging, but, if I don't use cocaine, but maybe I can do with the other ones. That is exactly talking about the second bucket that you're talking about, yeah? It's like the brain keep challenging itself a little.
I don't think it's a good idea for your friend to...
he wanted to... No, I know. He realized it, so he's not my friend. He just wanted to start therapies with me.
Your patient, yeah.
That's what I was trying to tell you. Sometimes, not most of the time, these thoughts may come. And if you're not guarded, if you don't go to AA or you don't have a therapist who understands from addiction, you may get caught in these crazy thoughts and you may find yourself using. That's what you were talking about, the second bucket, I guess.
Absolutely. Let me just address the issue of jumping from one addiction to another.
That was in my notes, so perfect. The cross addiction you're talking about.
Yeah. A lot of people believe that once you're addicted to a particular substance and you happen to stop that substance, then your chances of moving to another addiction, whether it is a behavioral addiction or a substance use disorder, is higher than the general public, meaning that having some kind of addictiveness in you puts you at the risk of being addicted to another substance or behavior. As it turns out, that is not the case.
Oh, really?
If anything...
It's the first time I'm hearing this.
Yeah, that has been researched quite well. Carlos Blanco and Wilson Compton from the National Institute on Drug Abuse did a major study on it and essentially dispel it. And the majority of people who quit their drug of choice, whether it is alcohol or cocaine or whatever it is, are at lower risk of entering another addiction than the general public.
Why?
Well, they didn't address the why, but I can speculate on that. I think that you develop skills in sobriety, you develop communities in sobriety, you develop insight in sobriety. I think there are lots and lots of secondary gains that one gets when they are sober, above and beyond simply stopping the drug.
Okay, let's clarify it, because I was suddenly I thought you were saying if you were addicted, let's choose substances, cocaine, if you start using ketamine, you won't get addicted. So you're saying that if you're in recovery, you have so many tools to stay sober or love life or being able to deal with your challenges in life. Therefore, you don't feel the need to start to another substance.
Or it's both carrot and a stick. It's both that you
or you're afraid that you're going to be...
Exactly, exactly. Or you know what a disaster it is and you stay away from it. But statistically, you do have a lower chance of going into a behavioral addiction or another substance if you're in sobriety.
Petros, I receive a lot of questions about some of the talks that I do. I got invited to a couple of podcasts. I would love you to explain it more scientifically. I'm going to say what I'm going to say now. So when I was in the rehab, there was Dr. Trancoli, and I was at Karen Treatment Centers. And the way that he described that the brain cannot differentiate the substances, there was a carpet with dots on it. So he was when you get closer, you're able to see the dots. But when you're far away, it's one pattern. You don't see the differences. And the way he explained that even the brain is smart. Once a substance gets into you, then the brain is going to be acting the way that you're maybe not as hype as, let's say, you're a cocaine addict and you're drinking, but it's going to affect the brain the same way.
Okay. I think he may have a good point for people below the age of 25. If you are a young adult or an adolescent, then what we do see is that people would pretty much use whatever is available to them. There are all kinds of street names for that, but people just jump from one thing to another, and as you said, everything is blurred, and it doesn't really matter what the substance is. But if you survive past the age of 25, there's a good chance they're going to precipitate to a drug of choice. I do have patients who come to me and say, doc, if there's a little bit of cocaine around, I won't mind. I will do like a line or two. But alcohol. Alcohol is my best friend. That's really the one that speaks to me. So there is such thing as a drug of choice. And there are animal experiments as well, where you get, let's say, rats addicted to morphine. If you get them addicted to morphine and then you inject them, let's say, with cocaine, they will respond very much the same way as if you were injecting them with saline. They won't differentiate between saline and cocaine if they're addicted to morphine. It's not like their brain has been addicted in general and they would bunch together morphine and cocaine. Quite the contrary. They are addicted to morphine, they stick with the morphine, and then everything else is just non-morphine. So, there is some specificity up to a point in the brain. For example, we don't think that the brain can really distinguish between cocaine and crystal methamphetamine. Neither the rats nor the humans. But certainly the brain can distinguish between alcohol and opioids and stimulants and major classes of drugs of abuse.
But I see a lot of people that, their drug of choice is, let's say, cocaine or X. Each time they drink, they go back to their drug of choice, even though they're trying to get sober. So how do you explain that action?
Yeah, and we have written about that. There are associations that people make. As you know, I am Greek, and there's a very, very well-established association between caffeine and tobacco in Greece. I wouldn't be that surprised if it is the same in Turkey. So as soon as you have a cup of coffee, you want to smoke a cigarette. As soon as you smoke a cigarette, you want to have a cup of coffee. And there's a very strong psychological association that has developed in someone's brain. And sometimes it's sequential as well. You mentioned ecstasy, methylene dioxymethamphetamine, MDMA. It's a party drug, and very often in party situations we see a sequential use of drugs, meaning that earlier in the evening somebody may want to be using stimulants to get all excited, and then later in the evening they may want to use something that's more sedating, and there's a whole kind of sequence of how to use different drugs. This is different than being addicted to different drugs. It's more of a polysubstance situation.
Are you saying that if somebody has a drug of choice of X, and then can they use recreationally alcohol or marijuana or?
No, certainly not.
Why not?
Because of all the behavioral components of addiction as well, and the social environments. As we know, it's a biopsychosocial illness, and you're tapping on the social components of it. So if you have associated crystal methamphetamine with a party scene and with sex, alcohol, as you mentioned, then there's a very good chance that any one of those three will trigger the other two. So not a good idea in terms of triggering people into using their primary drug of choice.
So what do you make of this saying, drug is a drug is a drug, so all mood-altering substance will be in the same basket?
I think this is an oversimplification. I don't think the evidence and the science supports that. I think there's much more specificity in the brain, again, after the age of 25, about different substances and the different behaviors. There are some potential exceptions, and we tried to study them. I don't know if you remember Dr. Rosenthal back at St. Luke's Roosevelt and I. We had the thought that people who suffer from atypical depression, sometimes called reverse depression, instead of having insomnia, you have hypersomnia. Instead of not being able to sleep, you sleep too much. Instead of loss of appetite, you have increased appetite and you may be binge eating. It's also called reactive depression because you don't look depressed. You may be the life of the party. Inside, you may be extremely dysphoric and depressed. And for these people with atypical depression, it may be that they could jump from one addiction to another, including eating disorders and behavioral addiction, sex addiction, substances, and the like. And the way that we tried to study that is to put people on two types of diets, one high carbohydrate diet and the other low. Anyway, I don't want to bore you with something because the study did not get funded, so we will never know, and I don't think anybody pursued that. But there is the bottom line here, what I'm saying is that there will be subpopulation, maybe not the majority of people, but some groups of people for whom this kind of idea of using some kind of substance or an addictive behavior to satisfy perhaps some kind of emptiness that they may feel inside or some kind of depression, that may actually happen. I'm not saying that that does not happen, but for the majority of people, there is such thing as specificity of different drugs or behaviors.
So let me repeat what I heard. So if it's under the age of 25, and when you start using, like for 3 years you used cocaine, before that you were smoking pot, and then you found out about ketamine, then now you develop some sort of a tendency to all of them. Therefore, that's not going to change after the age of 25.
Ezra, I'm not really sure if that's correct. I think that people who use different substances quite often eventually will precipitate to a drug of choice. Not everyone. There are several people who may have 2 or 3 drugs, but there is such thing as a primary drug for a lot of our patients. I don't want to belabor this point anymore because it's not something that is kind of such a big part of our work, but that's where we are at this point.
What do you think of this last couple of years? They started trying some psychedelics on addiction treatment.
I can say quite a few things here.
Yeah, please.
But bottom line is very promising, very encouraging data. Quite excited about both general psychiatric disorders like depression and PTSD, as well as treatment of addiction. Wonderful studies by Steve Ross and colleagues on the treatment of alcohol use disorder with psilocybin. So promising, encouraging, but we're not there yet. Don't suggest that clinically any psychiatrist or any prescriber gives patients these agents who have not crossed all our T's, who have not dotted all our I's, who don't know what happens in pregnancy, who don't know what happens to the kidneys, to the liver, who don't know what the addictive potential of these substances in the long run, drug-drug interactions, people who are on other medications. There are so many things that need to be checked. A few months ago, the Food and Drug Administration of the United States rejected methylene dioxymethamphetamine, MDMA, ecstasy, as a potential treatment for psychiatric disorders, not so much on the basis of efficacy. The efficacy data was there, but on the basis that they had not really crossed all their T's and dotted all their I's. This is an expression that means that they haven't looked at everything else that there is to see in terms of adverse effects and so on of MDMA. Similarly for psilocybin and the other psychedelics.
I met Steve Ross a couple of years ago. Yeah, maybe a good 5 years, maybe even more. He mentioned about the work, the study that it's still continuing, that study in NYU.
They published the results last year. They have other studies now as well, but this particular one on alcohol use disorder has been completed and published, and it's very well received. But if you were to ask me this question 5 years ago, I would put cannabis and psychedelics pretty much on the same boat, and I would say both have some potential beneficial effects, but we're very cautious and we're studying them, and the typical language that all of us use when we don't really know much about a particular substance. Since then, the data have come in and the two groups have really diverged. We're becoming more and more enthusiastic and more hopeful about the place of psychedelics in psychiatric treatments and addiction treatment more specifically. And we're getting more and more disillusioned and much more cautious and much more afraid of cannabis and cannabinoids as more and more data are pouring in.
Yeah, now that you open, let's talk about that a little bit, because I have so many parents reaching out to me, and the kids meaning like not even teenagers, young adults having like huge behavioral problems. I even had one with a psychosis. It's so difficult to convince them because they say, oh, it's allowed, it's legal, so-and-so is smoking as well. It's like a madness, and I'm sure it's the same thing in the United States. So what are you witnessing?
Well, we do see an increase in cannabis use, and exactly as you said, the fact that it has been legalized, not federally, but in a lot of states, the majority of states, for both recreational and what is called medicinal purposes, has given a false impression, especially to adolescents, that it's safe and it's totally okay. The other major misconception there is that it's natural. So if it is natural, it must be good for you, or at the very least, it will not harm you, which is hugely disrespectful to nature. I mean, nature has come up with more toxic things than we've ever been able to put together in a lab. So to just say that if something is natural, it's not powerful is absolute nonsense. But in any case, that's what is happening in the US as well, and we've seen a significant increase in cannabis. Now, from the point of view of somebody who's trying to treat some psychiatric disorder with cannabinoids, it's very, very difficult to see any kind of downside to it. Doc, I'm anxious. I take my cannabis. I'm not anxious anymore. Like, what could possibly be wrong with that? Why don't you want to recommend to me something that I know will absolutely treat my anxiety? Meanwhile, the number one reason why people use cannabis, more than the treatment of anxiety, more than the treatment of pain, more than the treatment of depression, more than the treatment of anything else, the number one reason why people use cannabis is the self-medication of cannabis withdrawal. The self-medication of cannabis withdrawal. That's the main reason why people use cannabis. The analogy for us in the addiction field is totally obvious. Someone is depressed, they take cocaine, they're not depressed anymore. The fact that the substance will absolutely treat a particular moment of dysphoria, depression, anxiety, malaise is obvious. That all substances at some point will give you something, maybe with the exception of PCP. But pretty much everything else will treat something at the moment. Alcohol, a wonderful anxiolytic. Benzodiazepines, they have the indication for the treatment of anxiety disorder in many parts of the world. Thankfully, in the US, they have been becoming more and more limited. But in any case, so from a patient perspective, it is very difficult to see why cannabis would be bad for them. It's natural, it is legal, it takes the symptoms away, boom, it's cheap, it checks all the boxes.
Yeah.
Except the one that it makes things worse in the long run. We certainly know that anxiety will get worse. There's panic disorder that has been associated with it. You mentioned psychosis. There are wonderful Danish studies that really have come just that kind of short of saying that cannabis will actually cause schizophrenia.
Yeah, I know that study. I had a program with Mark Fishman, and he was addressing to families, actually, and he had a wonderful saying. It's like, parents are feeling bad because at some point in their life they smoke, so they don't know how to say no to their kids. And he goes like, you know what? If you didn't wear your seatbelt when you were young, are you going to allow your kid to not to wear it? So that was wonderful, actually.
I like that. I'm going to use that for sure. Let's remember that the cannabis of our youth or our parents' youth has very little to do with the cannabis of 2025. The potency has gone up. The percentage of tetrahydrocannabinol, THC, in it has gone up. The synthetic cannabinoids like K2 and spice. So it's a very different world today than it was 20 or 30 years ago.
So, Petros, at the beginning you said that, you were interested into small molecules and you were interested into the big establishments, sociology and stuff. So what causes addiction? I receive a lot of questions. There's the gene part, there's the social part, So would you explain, please?
I think the classic biopsychosocial way of looking at addiction is still very, very helpful. On the biological side, you mentioned the genetics, very, very well established for alcohol, pretty well established for opioids and stimulants. And these days, we also feel that behavioral addictions may have a genetic component. I'm very much thinking about gambling, significant evidence of a genetic contribution to gambling addiction.
You mean like our parents, grandparents, or like...
Absolutely. Yeah. That is something that is not quite as well established as, let's say, for alcohol, but it's quite significant data to support that. On the psychological side of this triad of the biopsychosocial model, things get a little more complex. We used to think that people start using drugs to get high. That was all there was to it until self-medication came around, the self-medication hypothesis, that said, no, it's not that like people feel normal and they want to jump to an outside world. it's the other way around. People feel miserable, people feel disenfranchised, people feel alienated, and they use the drugs in order to normalize. People don't do drugs in order to escape. People do drugs in order to arrive. The classic premise of self-medication. Now, in 2025, we appreciate both sides of this psychological reason why people may use drugs. Sometimes people use drugs in order to get high. Sometimes people use drugs in order to self-medicate. Don't let anybody tell you that all there is to addiction is getting high. Don't let anybody tell you all there is to addiction is self-medication. Both of them are significant psychological components on people using drugs. And these days, we also appreciate the third psychological reason why people may use drugs, and that is performance enhancement. Performance enhancement, I'm talking about anabolic steroids for better sports performance, methylphenidate and stimulants for better school performance, sildenafil, tadalafil for better sex performance, the erectile dysfunction agents. Very difficult to argue that these people are using the drugs to get high. Very difficult to argue that these people are using the drugs to self-medicate some kind of underlying untreated psychiatric disorder. It's a third slab, absolutely fascinating, lots of ethics going in there, social determinants of health, who has access to these agents, who can get ahead in life, who has the money to buy. So there's a lot of these things going on with the performance-enhancing agents. And then finally, there's the third component, the social cause of addiction, the microenvironments, the subcultures, the neighborhoods within which we all live and love and play and work that may very, very well define the addiction. So you bring all these things together in some kind of particularly complex fashion, and that can very much get the person addicted. This is the fundamental model of addiction, how we understand in 2025. But I want to caution people that this biopsychosocial model has a major flaw. Taken to the extreme, it suggests that in the absence of significant biopsychosocial forces, the risk of addiction is negligible. Let's think about this for a second. You have a 16-year-old kid, and her parents do not smoke cigarettes, her grandparents do not smoke cigarettes, no biological risk factors for addiction to tobacco. Let's say she does not have ADHD, she does not self-medicate against anything, no psychological reasons why she would use tobacco. And let's say her social environment, her peer group, do not smoke cigarettes. She doesn't have any kind of peer pressure, no social reason to start smoking cigarettes. Would it be okay to go up to her and say, smoke away? You can smoke all the cigarettes in the world you want, and you will never become addicted to tobacco because you lack the true causes of addiction, which are these biopsychosocial forces. That would be completely insane. And yet, that's exactly what we thought at some point about opioids. At the very core of the opioid epidemic lies a fallacy, a mistake that we made, that we thought that people who do not have significant biopsychosocial risk factors will be risk-free for opioids. And that's where these doctors start prescribing these massive amounts of opioids. Essentially, they would say, you don't have biological risk factors, you don't have psychological risk factors, you don't live in this down-and-out, drug-infested neighborhoods, nothing to fear, prescribe, 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 prescribe. And that's why we've changed the model. And these days, we not only talk about biological, psychological, and social factors in addiction, we have also added the use of the drug itself, the very molecules of the drug entering your body as an independent additional risk factor for addiction. The majority of people who got addicted to prescription opioids in the early 2000s had no biopsychosocial risk factors whatsoever. They just were laborers, they got lower back pain, they went to the doctor prescribed these massive amounts of opioids, and before you know it, they were addicted.
I think Anna Lemke, we're saying like there's a 50 to 60% genetic factor. Nora Volkov also wrote about like there's not one gene and gene combinations, so it's very difficult to identify which gene is it.
Correct. There is a complex picture of different genes that contribute to different addictions, but that does not take away from the fact that the genetic component of addiction is quite strong. No question about that.
Because we hear a lot of people like, oh, we don't have anyone in the family, and boom, they ended up being an addict. And that's kind of like because the substance that they're using is so potent that it's very easy to create tolerance.
Yes, not only tolerance, but addiction in general. I mean, cocaine as well. So you don't have to have all of these factors in order to get addicted. You don't have to have biological, psychological, social, and use vulnerabilities in order to get addicted. As I mentioned before, the prescription opioid epidemic in the United States started from people who only had use of the drug prescribed by physicians that got them into the addiction. There was a time some time ago where Alcoholics Anonymous and other mutual health programs would say that if a doctor prescribes your medication, then that's perfectly fine. And if you take the medication as prescribed by your doctor, then that is allowed and it's perfectly okay. We don't feel that way anymore because, again, all these opioid addicted people, they didn't take. The majority of people who got addicted to prescription opioids did not take a single pill above and beyond what the doctor prescribed. Very little known fact. Some people think that addicted people are drug shopping and they go around and irresponsible. No, the majority of people were absolutely responsible with the way that they took the medications as prescribed.
Petros, for our last part, let's touch base on treatment. We talked about the negative. What we're struggling in Turkey, unfortunately, we do not have rehabs. We have some, what they call treatment, but more like a stabilization meeting detox, like 10 days, 15 days. But we do not have a true treatment that will help the person to change also their behaviors. So, it's tough. I try to send people to United States most of the time if they can afford. Other than that, over here, it's like a revolving door. They get in and out, in and out, in and out. And it's like, all of you guys say that it's so much more dangerous to be in and out to a detox or like a 10-day inpatient stay. Why would you guys say that?
So I hear you, and it's maybe a little better in the United States, but we have lots of communities that are way underserved, and what you're saying rings very true for big parts of the United States as well. If I were to boil it down to one thing, one recommendation would be to engage the primary care physicians, to engage the primary care system. We did that with depression 30 years ago, and it was a major success. Depression used to be treated only by psychiatrists and psychologists, and then perhaps because of the safety of medications, of the SSRIs and SNRIs, it moved from the specialist's office to the primary care office with huge success. Of course, we still see depression, and of course, still specialists see complicated case, but the vast majority of depression treatment happens in primary care settings. I think that the similar thing should happen with addiction. I'm not saying that this would be adequate for all cases. There will certainly be complex cases, comorbidities with other psychiatric disorders that would certainly need specialized treatment, but a big chunk of the addiction treatment burden can be addressed in primary care settings. For two addictions, or for 2.5 addictions, the two addictions I'm thinking about is tobacco and opioids. Primary care physicians and other providers can do wonderful work. What am I talking about? Just putting somebody on varenicline or nicotine replacement therapies if they use tobacco, put somebody on buprenorphine if they're using opioids. The medications that we have for tobacco and opioids are incredibly robust, and they do a wonderful job for a lot of patients. The other disorder also we do have safe and effective medications is alcohol, and primary care physicians and other providers can do very good work with alcohol as well, especially in combination with mutual help groups like Alcoholics Anonymous. Things become more complex and more difficult when it comes to stimulants, when it comes to cannabis, when it comes to the behavioral addictions. I do think engaging the primary care system is a huge first step in the right direction.
So let me put you on the spot. What is an ideal treatment for you? Inpatient, let's say.
It depends on the addiction. For example, as I mentioned, tobacco and opioids, the most effective, the most powerful treatment would be medications. And they're so strong that they can carry the burden of illness on their shoulders. When it comes to alcohol, medications can be helpful, but I would say that 12-step programs, Alcoholics Anonymous has done an amazing job worldwide on the treatment of alcohol use disorder. And then when it comes to stimulants, it's probably contingency management. Contingency management would be the intervention of choice. CBT, cognitive behavioral therapy, motivational interviewing, cut across pretty much all different addictions, both behavioral addictions and substance use disorders. As somebody who is trained in cognitive behavioral therapy or motivational interviewing can do a wonderful job with our patients. Mindfulness is another major component that is emerging in the treatment of addiction. And if you have the skills of providing mindfulness treatment, that can also be tremendously helpful. And of course, again, across all the addictions, treatment of co-occurring psychiatric and other medical disorders goes without saying. That increases the chance of success significantly.
Yeah, you're right. You know, when I started my internship with you guys, you know, because I learned the total abstinence, the sobriety, I mean, it blew my mind. It was like more harm reduction, the program, correct? I'm like, you know, how is that going to be possible? I was like a bit surprised. I got used to it after a while. Can you explain what is harm reduction?
Back when you were at the Addiction Institute, we're talking about maybe 15, 20 years ago or so, there was a big war between abstinence models and harm reduction models. And the war is over. Harm reduction won.
Okay.
It won, totally. I mean, like, you cannot possibly be any kind of provider and not embrace harm reduction. If you say, I'm against harm reduction, you're a goon of yesteryears, you will be dismissed. But harm reduction, in a sense, is an umbrella term. It's an orientation that is very valid, of course. It says our primary concern here is to reduce harm for our patients. But it's just such an umbrella term. It's just so kind of wide that it has at times become meaningless. Of course, everything that we do in all of medicine, in all of caring for patients, will try to reduce harm. That kind of goes without saying. So if you want to have more of a kind of pointed discussion, then it becomes more like a moderation management. When is moderation management something that is helpful and when it is not? Because other parts of harm reduction, let's say needle exchange to reduce HIV risk, or methadone for opioid use disorder, buprenorphine for opioid use disorder, these are things that pretty much everybody agrees on. But moderation management for alcohol, moderation management for, let's say, crystal methamphetamine, these are kind of highly debated issues and not all that easy to address. Yes, we do appreciate reduction in heavy drinking as a major research outcome. We used to only look at how many days abstinent are you, let's say, in alcohol research. In 2025, we'll have how many days of abstinence do you have, plus how many days of reduced heavy drinking you have. So we appreciate both sides of these outcomes in, let's say, alcohol research. That's where we are today. There are specific debates that do continue, but the overall orientation towards harm reduction, I think, it goes without saying.
Let's end with what's exciting you, what's waiting in the addiction field that is coming and it's going to be changing the whole field, if any.
I like the if any part. And I'll tell you why I'm saying that, because my main interest is not so much in finding new treatments for addiction. It's much more taking the treatments that we already know work very, very well and disseminating that kind of information and implementing this kind of very safe and effective treatments that we have to so many people who would benefit from them, but either they do not know about them or they do not have the means to access them, or their doctor does not know anything about them. So it's much more of an issue of implementation of what we already know into where it is absolutely needed. That's what really excites me. That if I were to see a world where anybody who would benefit from buprenorphine would have access to buprenorphine, that would be wonderful. If anybody who could benefit from contingency management that we mentioned before would have access to contingency management, that would really, really excite me.
Thank you so much. That was a great new informations actually for me, because you're just on top of everything. And it seems like there are a couple of things that I need to renew myself about. Thank you, Petros, for your time.
So wonderful seeing you, Ezra. And thank you so much for having me in your program.